Okay, we are live.
Thank you so much, Jennifer. Good afternoon, everyone. It's great to see everyone, right? It's been an unprecedented, amazing year and very challenging. So it's great to see you. On behalf of Senator Feldman and I and staff, we welcome you to the Maryland Health Insurance Coverage Protection Commission. And this is our first meeting of the year. As you know, we are required to meet during the year and then have a report in December. And a lot of our efforts have actually produced amazing legislation. So I want to thank the commissioners for your time, for your effort. And it's really worth it because you see the results. And Senator Feldman and I are very grateful. And also the chair, Senator Kelly of Finance, and also Shane Pendergrass, the chairman of ACO. We thank you for your work. This commission last met in December 2020. Since that time, we have a new Secretary of Health and member of our commission, Dennis Schrader. Welcome. I don't know if he's on the call today, but we want to welcome you. And he replaced former Secretary Robert Bobby Neal. I see Mr. Webster Yee from the Department of Health on here. So the summary of 2020 annual report, in December, the commission submitted our fourth annual report. The report noted that the commission did not opt to pursue establishing a standardized benefit design or basic health program for Maryland. And this commission discussed it. I mean, this is the beauty that we are very open with each other. We have an honest, transparent discussion, and then we make the recommendations. The commission indicated a desire to seek additional information through a study on pursuing a Medicaid buy-in. DLS is currently in talks with Wakely Consulting to do a high-level analysis of a buy-in proposal. More detail to come soon, and we're all going to be part of this discussion. The commission expressed support for the Maryland Health Benefit Exchange to pursue a young adult subsidy pilot program with the Maryland Health Benefit Exchange reporting back on the impact and long-term care costs. I want to thank Michelle Everly, a member of this commission, for being part of the discussion. The commission deferred making a recommendation on whether to adopt a state-based individual health insurance mandate until the Maryland Easy Enrollment Health Insurance Program Advisory Work Group submits a forthcoming report that is actually due December 1st, 2022, so in a few months. We also expressed continued support for the state reinsurance program that has been a success. Thank you so much, commissioners, for your work and staff for your hard work, and recommended that the program be extended past 2023. A majority of commissioners also supported extending the assessment at an amount sufficient to continue the current program. The commission also recommended that the Maryland Health Benefit Exchange and the Maryland Department of Labor continue to work together, actually, which is really important, to establish a means to connect unemployment insurance claimants with health insurance coverage options. And that is so important, especially given COVID and what our constituents are going through. So I want now to do a summary. Those were the recommendations for our report when we submitted it last December. Now I want to tell you what came out of it legislatively. So linking the unemployment insurance claimant on with health insurance, Chapter 49 and 65 of 2021, this past session, require the Maryland Department of Labor to implement a system through which unemployment claimant may consent as part of their weekly claimant certification to the sharing of relevant collected information by the department with the Maryland Health Benefit Exchange and the Maryland Department of Health, so that the information can be used to determine whether the individual qualifies for free or low-cost health insurance, and if so, to help the individual enroll. So that was a recommendation of this commission, and it actually passed. Your recommendation, our recommendation, was accepted by the legislature, and it's now law. The Young Adult Health Insurance Subsidy Pilot Program, which was the other recommendation, actually Chapter 777 and 778 of 2021, required the Maryland Health Benefit Exchange to establish and implement a state-based subsidy adult health insurance subsidy pilot program. So again, that became law. And in establishing the subsidy eligibility and payment parameters for the 2022 and 2023, the Maryland Health Benefit Exchange must consider young adults who are between 18 and 40 years old with incomes between 133% and 400% of the federal poverty level. This is also subject to available funds. So in fiscal 2023 to 2024, the Maryland Health Benefit Exchange may designate up to $20 million in funds from the Maryland Health Benefit Exchange Fund to be used for the pilot program to provide annual subsidy in calendar years 2022 and 2023. Again, that was a recommendation made by this commission, your work, that became law. So I want to summarize what we're going to do today, the agenda. So the summary for today, this afternoon, we're going to hear 3 presentations regarding policy developments nationally, the status of our state reinsurance program, and the implementation of the Maryland Young Adult Subsidy Program. So now I'm going to pass this portion of the agenda to my wonderful colleague, my partner in crime, Senator Brian Feldman, who will actually take it from here, and we'll do the hearing this afternoon. Thank you.
Okay, well, thank you, Delegate Pena-Melnick, my co-chair. I just want to reiterate that this commission, which was created 4 years ago, we've produced 4 reports. It really has been kind of provided a blueprint for a lot of the good stuff that we've later done in the Senate Finance Committee and the HGO committee over on the House side. So, as Delegate Pena-Melnick just mentioned, first up, we are going to sort of get a presentation about what's happening on Capitol Hill. You know, that interplay between what's happening in the United States Congress and how the states respond and react is really pretty important. And so the first presenter today is Ms. Joanne Volk, who is a research professor, founder, and co-director of the Center on Health Insurance Reforms at Georgetown's University's McCourt School of Public Policy, where she directs research, authors papers, and provides technical assistance on state and federal regulation and legislation governing private health insurance, including health insurance marketplaces under the Affordable Care Act. I do see Ms. Volk here, and welcome to the Maryland Health Insurance Coverage Protection Commission. So with that, I'll just turn it over to you to give us some guidance or update on what may be happening on Capitol Hill, germane to the work of this commission and ultimately the General Assembly of Maryland.
Okay. I think I have some slides. Yeah. First, I have to say I'm a proud resident of Maryland, District 20. So it's nice to be among fellow Marylanders. Just a little bit about the Georgetown Center on Health Insurance Reforms. We're a team of about 10 who focus on private insurance reforms at the state and federal level. We do publish posts and papers and conduct research, but also provide technical assistance to state and federal policymakers and some consumer and patient groups on these federal and state rules. Am I to advance these, Jennifer, or? Yeah, okay. And we are part of the McCourt School of Public Policy. You can go to the next slide. So today I'm going to provide an update on 2 big pieces of legislation that have far-reaching impacts for states and consumers, the No Surprises Act and the American Rescue Plan Act. I'm going to provide some updates on administrative action recently, certainly the COVID enrollment opportunities, but also some rules that are rolling out this soon in this fall, governing state insurance markets and the marketplaces in particular. And then just a high level touch on some recent state action on some issues that I think are of interest to you all. Next slide. The American Rescue Plan Act had historic improvements in affordability for Affordable Care Act plans, marketplace plans for all consumers. They lifted the cap that now means that those at 400% of poverty no longer qualify for subsidies under the ACA, and under the American Rescue Plan, they lift that cap and everyone is eligible for some subsidy that caps their premium contributions as a share of their household income. And it really did provide more generous subsidies across the board. So those up to 150% of poverty qualify for tax credits that fill in entirely for their benchmark plan. So they pay $0 out of pocket for a marketplace plan, a silver plan. And even up to 300% of poverty, where people under the ACA were required to contribute about 10% of their household income towards premiums monthly, is now capped at 6% for this year and next year under this, these temporary subsidy enhancements of the American Rescue Plan Act. And across the board, no one will pay more than 8.5% of their income towards their premium, regardless, even for those above what was the cutoff for the Affordable Care Act. When this new law went into effect, the Kaiser Family Foundation estimated that about 8 million people were, would be eligible for premiums. About half of those were uninsured because they fell on the other side of this cliff that would have paid premiums entirely out of pocket without federal subsidies. I should say too that these are retroactive. So as long as someone's enrolled in a marketplace plan, I think I saw Johanna on here. I think the Maryland marketplace was able to adjust pretty quickly and provide people with this upfront relief. But for those who wanted to go back and grab what they would have been entitled to beginning January 1, they can do so when they reconcile their premium tax credits with their tax filing next year. So it's a year's worth of enhanced subsidies and will continue through next year. Next slide. The other big piece of the American Rescue Plan Act was to provide extra help for people getting unemployment insurance. So long as an individual would get benefits for at least 1 week in this year, they would be eligible for marketplace benefits that would treat them as if they were an individual with household income of 100% of the federal poverty level, which means they would get that zero premium plan, but also the most generous cost sharing reduction plan that has an actuarial value of about 94%. This too is retroactive to January 1, at least the premium enhancements, meaning people can claim that credit for months that they didn't get them up front as advanced tax credits. The cost sharing help though is not retroactive, it's only prospective. Next slide. The other big piece of this was subsidies for Cobra coverage to cover 100% of the Cobra premium for premiums from April 1 to September 30th. So it is ending soon. The subsidy extends to state mini Cobra laws like Maryland's own mini Cobra law to require Cobra coverage even of small employers. But it does not apply to those who voluntarily terminate employment. The companion piece to this is that the Department of Labor had, even prior to this new law, provided greater flexibility to employers and employees with the usual Cobra timelines for providing notice and electing coverage. So for the employee or former employee, if they missed that 60-day window to sign up for Cobra when they were initially eligible, the DOL guidance allows them to reopen that 60-day window and elect Cobra so they can take advantage of this subsidy while it's in effect. The other big federal law I want to talk about a little bit, and I think some folks on this call are probably working on implementing this or getting ready for it. Beginning in January of 2022, there is now a federal ban on balance billing in certain circumstances for all emergency services, which includes air ambulance, but not ground ambulances. And for non-emergency services provided by an out-of-network provider at in-network facilities. With this federal law, it extends protections to the nearly 135 million people in self-insured plans that can't be captured under state law, like Maryland's, and to those insured in states that don't have their own protections. And so the patient will be responsible only for in-network cost sharing where these balance billing protections apply, and that cost sharing must count towards their in-network deductible and out-of-pocket limit. There are some exceptions. Patients can be asked to waive their rights to balance billing protections. An out-of-network provider can provide them with a notice of their protections and ask them to waive those protections so long as they include a good faith cost estimate and help them identify available in-network options. Those notices, we've seen draft and model notices from the feds, and they're finalizing those now. But in all cases, the protections cannot be waived, even where, you cannot ask a patient to waive these protections where there is no in-network provider available for urgent or unforeseen care and for services delivered by providers in certain designated specialties that typically have been sort of the usual suspects in these surprise bills, like anesthesiologists, pathologists, radiologists, and others that the secretary may designate through rulemaking. The big issue that's always been a stumbling block, and I'm sure this came up in the legislative battles in Maryland, is what to actually pay the out-of-network provider. Under the federal law, the health plan or insurer can, within certain timeframes, negotiate a payment with the out-of-network provider or facility. If that fails, they can elect to go to independent dispute resolution that has some parameters on who conducts that arbitration and the factors or how to arrive at that payment standard. Next slide. But like other federal laws, this is a partnership with the states. The state departments of insurance are the primary enforcers of the provisions that apply to insurers and fully insured group health plans. The law specifically defers to states that have their own balanced billing law that determines payment of out-of-network rates, and to states with an all-payer model agreement. I think Maryland should tick both those boxes, so that for fully insured individuals, the Maryland law will prevail, but we have yet to see how that gets addressed in rulemaking. And then the state law can apply where it is more consumer protective. This is also like the Affordable Care Act. The federal law sets a floor, but states can go beyond that floor. So one area where this might occur, for example, is the notice and consent protections. There are some states that don't allow consumers or patients to waive their protections in any case, and those would be considered more consumer protective. And just like with other federal laws, like the ACA, the DOL, the Department of Labor, regulates self-funded plans, and that will apply to the out-of-network providers and facilities and how to resolve payment to them for self-funded plans, but also for the other No Surprises Act provisions like notice and consent and disclosure. There are a few other provisions. It was a big bill tacked on at the end last year. It was a bit of a surprise that it got over the finish line, but it covers quite a lot of territory. There's also an independent dispute resolution process for uninsured individuals who can show that their good faith cost estimate that they get in advance of their care substantially exceeds the actual bill. We haven't seen the rulemaking on that yet. There are continuity of care protections where if a provider contract ends, certain patients have the right to maintain access to their provider with in-network cost sharing. Typically, for example, patients with terminal disease or certain in pregnancy cases or acute care to allow them to continue with their in-network provider. There are also new requirements that provider directories must be kept accurate and up to date, with requirements on both the plans and the providers to update them no less frequently than every 90 days. And there is a new set of funds to states to fund their all-payer claims databases, either to establish one or to improve one that they already have. And I should say, we have out the first of what will be a few rules from the feds on implementing this. There was an interim final rule that just closed for comment 2 days ago or yesterday that addressed notice and consent and the disclosure, but we are still expecting more rules on actual dispute resolution and for the uninsured and where balance billing occurs. And in actually greater detail on the enforcement and the partnership with states to enforce this federal law. Turning now to administrative action, of course, the feds opened up healthcare.gov for a COVID special enrollment period that ran from February 15 to August 15. State-based marketplaces also created their own SCPs. Some ended sooner than the federal, some extended beyond, some are still in effect. And the feds estimated that about 2.5 million people combined across the federal marketplace and SBMs enrolled during that period of time with this SCP. And then they also created a special enrollment period for the loss of this Cobra subsidy that I said comes to an end at the end of this month. Typically, if someone elects Cobra, they have to wait till they exhaust their 18 months or 36 months in certain cases, or enroll during open enrollment and coordinate the end of Cobra with the beginning of their marketplace plan. So this recognizes that people will sort of be stuck without other options without this SEP when the subsidy ends at the end of this month. The other big area of rulemaking is the annual notice of benefit and payment parameters. This is the sort of comprehensive rule that updates insurance rules, including for the marketplaces. We've had two now that revisit the payment parameter rule for 2022, the rules that'll be in effect next year, two from the Biden administration, basically reversing much of what the Trump administration had finalized on the final days of their administration. One is that they reversed the Trump administration's revisions to the methodology that calculates how much, where to set the annual out-of-pocket cap. And they sort of changed the methodology and some inputs there so that it would rise much more quickly. By reversing that methodology change, the Biden MBPP will save consumers $400 a year for those that reach that cap. There is a second rule updating parts of this 2022 rule pending now. We should see it finalized, we think, this month, that proposes to extend open enrollment by 1 month. So it'll spill into January of middle of January next year, and creates a new SEP for low income individuals. Those with income below 150% of poverty will monthly be able to enroll or change their plans. And then the rule asks for comment on the specific start and end dates for this OE, and whether or not states should be able to continue to do something different on those dates. The other big change the Biden administration proposed and is still pending in this second part of next year's rule is the guardrails for the 1332 waiver, state innovation waivers. The administration, the previous administration, redefined guardrails that are essentially meant to protect consumers, that even under a waiver, they should be made no worse off in terms of how many people are enrolled, how much they pay out of pocket for their coverage, and the generosity of the adequacy of their coverage, that they should not be made worse off. And then there's a fourth guardrail that it cannot increase the federal deficit. The Trump administration redefined those guardrails to basically say, as long as people have access to good enough coverage, that counts. And by the way, we'll also count people that enroll in non-ACA plans. So there was absolutely no protection to ensure that people would not be made worse off if their state elected to pursue a 1332 waiver. It returns to the Obama era guidance with the guardrails as previously written, and also the requirement that they have to take into consideration the effects, not just in total, but on particular populations like older adults, those with serious health conditions or at risk of getting serious health conditions, and people of color and others who've been historically underserved, marginalized, and adversely affected by persistent poverty and inequality. And an application that fails to demonstrate that it meets the guardrails for each of those subpopulations and not just in aggregate is unlikely to be approved. One area of interest, particularly for some states and advocates, is that the rule did not revisit this deficit neutrality guardrail that I mentioned. And there is some concern that if a state meets the other three guardrails, that they come up with a way to do this differently, but still cover at least as many people for at least as good coverage and pay no more out of pocket, that you're bound to bust that deficit neutrality guardrail. If you enroll one more person, you've already spent more money for the feds. And so people are really sort of struggling with how they pursue certain innovations that try to improve coverage without running afoul of that fourth guardrail. And we did not see this administration revisit that in this rule. Next slide. And then no sooner will we have a final rule for 2022, but we know that they're busy at work now finalizing the rule that will be out for comment for 2023. And the feds have indicated that in response to a lawsuit, the city of Columbus versus Trump, in which they found that one of the Trump payment parameter rules did not follow the Administrative Procedures Act. So some of the provisions finalized there have to be revisited. Two here, I mentioned standardized plans. Previously, these were an option in the federal marketplace, and the Trump administration eliminated that. So under the Columbus decision, the administration is revisiting standardized plans, whether or not to allow them or require them in the federal marketplace, and what those plans would look like. And we understand they're looking at state experiences to craft what those plans might look like. 8 states, as you know, currently require standard plans. And then the other big issue that's going to be revisited here is one that's sort of been languishing for a while: network adequacy. When last the feds had this, they were checking states' work to oversee sort of a second layer of review for network adequacy, and had proposed certain quantitative standards for issuers in the federal marketplace. They may, at a minimum, reinstate federal oversight, but there's reason to believe that they're more holistically looking at revising those standards and setting new standards for the ACA marketplaces across all states. So with that, I want to turn just briefly to some highlights of recent state action. One area that I think is of interest is in public option. This is a term that very much depends on the person who's proposing it. It takes many forms, we've learned, from single payer down along a continuum to, I think, what we've seen in the 3 states that have adopted this so far, we call them public option style laws, in which the state has taken, has set heightened standards for privately funded plans, not proposing a public plan for offering on the marketplace. Washington was the first state out of the gate, and they had plans this year open for enrollment, but they were able to produce public option plans in only about half the state's counties, and the enrollment was only about 2,000 individuals across those 19 counties. So they've gone back to the drawing board and made some tweaks. Colorado and Nevada have also enacted legislation and are sort of following Washington's lead and learning from their experience. If you go to the next slide, I have some highlights. I share here a link to a post that colleagues have done that provides more detail about various elements of these 3 programs, but I wanted to highlight just a few here. The differences in where these public options are available. In Washington, it's just in the individual marketplace. In Nevada, it's the individual market, those ACA plans, whether they're available on or off marketplace, and they may add small businesses in future years. And then in Colorado, it's both markets, small group and individual, on and off the marketplace. One of the key goals of a public option is to control costs. They've used different mechanisms to get there. Washington capped the provider reimbursement rates, but that was seen as one of the contributors to not being able to produce a plan in all counties because they had hospitals that wouldn't participate. Nevada set premium reduction targets, fairly modest, 5% lower than the benchmark plan. Colorado has premium reduction targets that ramp up over time, the beginning at 5% and growing to 15% reduction in premiums, and sort of the hammer of setting provider reimbursement rates if plans can't meet these targets. The other side of the coin of the cost containment is provider participation requirements. So when you've capped or set these premium reduction targets, how do you ensure that providers participate? Again, Washington has had to go back to the drawing board, and they've decided to tie it in this year with, or for plan offerings next year, that if you are a hospital that participates in a plan with Medicaid or the state employee plan, public employee plan, if offered a contract from the public option, you have to participate. So it's one way to compel hospitals that were reluctant to participate this year to do so next year. Nevada and Colorado are also trying to figure out how to construct a hammer so that their cost containment goals with these premium reductions don't result in inadequate networks or not being able to produce a plan in all counties. They all 3 anticipate some role for a 1332 waiver to grab back some of that federal pass-through money for different purposes, and have, as I said, Washington's in effect this year. The other 2 are starting later. And again, I recommend this post for a deeper dive on some of these and other elements here that I've talked about. I did want to just give a quick update. Maryland was the first out of the gate with this easy enrollment, and we see now other states following, Colorado and Pennsylvania. are going to be implementing it for next year. Virginia will do it for their marketplace coverage in 2025, beginning sooner for their Medicaid program. And we know that legislation is pending in Maine and New Jersey, and it was considered in this last legislative session in New Mexico. Other states are thinking about variations on this, like Massachusetts and California, to use some of what you were talking about at the top of this call, applying for other benefits to enroll or identify people who are eligible for subsidies. And then just briefly on reinsurance, you may have heard with the enhanced subsidies, that means that states are going to pull back more money in their federal drawdown funds or pass-through funds with the reinsurance programs. And actually, the feds just announced yesterday more money coming to those states with reinsurance programs. Maryland will get $140 million more because of these enhanced subsidies when you calculate that into the reinsurance program. I do think there's a question about if these 2-year subsidies are made permanent, does that change the calculation for states adopted to do reinsurance because it was a way to lower premiums for the unsubsidized population? If you have a federal subsidy for all, regardless of income, it might change the discussion about what the role of a reinsurance program and the state funding that goes towards that program. But we're not there yet. Next slide. And part of that is because we are still very much waiting to see. We expect some activity in the House to make those premium subsidies permanent and not allow them to lapse at the end of next year. The other thing, but that's very much up in the air about whether or not they have the funds to pay for that, and the reception in the Senate. So it's a steep climb at best. The other thing under discussion right now, that though it doesn't directly affect Maryland, is they're trying to identify a coverage option for those states that have refused to expand Medicaid. And I guess the one thing I would say that might come back to states like Maryland that were early adopters here is, frankly, it's a bit of a challenge to figure out if you're going to do something where you pick up the tab in those states that would have otherwise been a shared state federal cost if they expanded Medicaid. How do you prevent those states that already expanded Medicaid from sort of dropping and taking advantage of this new option that puts more of the cost on the feds? And I think it's this is always the challenge. Those states that were early adopters for CHIP, how do you not disadvantage the states that did the right thing early on while still accomplishing your goal here? So that's very much under discussion. The other piece is federal action on the family glitch. These are those families where when you look at the offer of employer coverage, it may be affordable for the employee, and so they can't get premium tax credits, but the employer may not subsidize at all or very little for the dependent coverage. And though it's not in reality affordable for that family, they are barred from getting premium tax credits. That's what we call the family glitch. There is one path that fixes this legislatively by a change to the law, another path that says there's a way to do this with a change in the regulations. And I think folks are waiting to see if either might happen, so those individuals can access care, the subsidies and coverage. And then finally, we'll be watching to see whether or not there's federal action on the public option. 2 committee chairs in the House Energy and Commerce and the Senate Help Committee asked for stakeholders to submit comments at the end of July to inform their future discussion or legislation, but we don't know how much further that's going to go. I do want to point out that Georgetown is developing a resource with Arnold Family Foundation funding that's going to be a sort of one-stop shop for all information on public option, tracking federal and state efforts, and some good resources about some studies out there, including quantitative studies on what this actually means for premium reduction for those states that were trying to achieve that, or in different models that you might pursue. So as soon as that's available, I'm happy to pass it along to folks. It could make for a easy way to catch up on the public option debate, including in the states. And that's it. I'm happy to take questions if there are any.
Well, that was really outstanding, Ms. Volk, and I appreciate the fact that you're from Montgomery County. That's icing on the cake, District 20. Okay, so as far as, I think the easiest way to handle this would be, most of you probably know how to get to your version of the raise hand function, either depending on which program you have. It's either going to be in the participants box, or I think in some versions of Zoom, you have to go to your reactions sort of place to do a raised hand. And so if you've got some questions, there's a lot of information covered here. Why don't you raise your hand? And if those two things fail and you can't find your raise the hand, we have a pretty small group here. Okay, well, I've got Vinny DeMarco leading the charge here with the first question. Vinny, unmute yourself and ask your question.
Thank you, Mr. Chairman, and thank you, Joanne, for the great presentation. A couple of quick updates on the easy enrollment piece. Colorado passed legislation, but Pennsylvania is doing it by administration without legislation, which is very exciting. And other states are going to be looking at that also. In addition, all the states that are considering easy enrollment are making great use of a video that Speaker Adrian Jones put together about how great the Maryland law is, and with our wonderful lead sponsors, Senator Feldman, Delegate Pena-Melnick, and that video has been used in all these states. And finally, Senator Chris Van Hollen is about to introduce a national easy enrollment law, which will also include auto enrollment. And that will be very exciting. And we are working closely with him and Stan Dorn to put some parts of it into the reconciliation so it could pass this year. So we're very excited about what Senator Van Hollen's doing, and easy enrollment is sweeping the nation.
Okay, well, thanks for that shout out, Vinny. Okay, so any additional questions? Why don't you go ahead and raise your hand? Okay, don't be shy here. I don't see anybody. If you're having some trouble finding your raised hand and you really want to pipe in, just unmute yourself and I can acknowledge you there. Because we've got, again, Joanne Volk from Georgetown is a real asset. Take advantage of it.
This is Sandy Walters.
I see Bob Atlas has his hand raised from the Maryland Hospital Association. Bob?
Right. Yeah, thank you, Senator. And Joanne, thanks for the good presentation. You said something earlier, it was one of your slides, it was about, I think it was about the balance billing provision, or about the cost estimate. Wait, I think it's in the No Surprises Act part. Keep going down. It was there on slide 11, where it says independent dispute resolution for uninsured whose good faith cost estimate substantially exceeds the actual bill. That feels like it's upside down. I mean, wouldn't it be that the bill substantially exceeds the cost estimate?
Yes, sorry. Yes. You absolutely.
All right, I'm not
where
looking
what
to
you're
like,
actually billed exceeds substantially the estimate they gave you up front.
Okay.
So yes.
all right, good. I'm not like
No.
trying to like.
I'm not sure
find
how
errors.
helpful that would be, but
All right.
my version, your version is
Okay.
actually the
But I
law.
appreciate the clarification. Thank you. That was it.
Okay.
Hey, Joanne, I want you to think that members of this commission just show up and kind of, we actually look at the PowerPoints and
Yeah, I should have shared it for
very
review and edits
involved.
in advance of my presentation. Good catch.
I want you to leave this presentation very impressed by the members. Okay, any other questions? I don't want to force anybody to ask any questions if they don't want to.
This is Sandy Walters. Can I ask?
Yeah, Sandy, go on. Sandy Wall.
It was an excellent presentation. Are we going to be sent a copy of the slide decks for all the presentations today?
We did send out the slides earlier today, so we can resend them again if you didn't get it, certainly.
I'm not caught up on my emails today. I've been
Okay. Well, Sandy, if it didn't show up, let us know. We'll resend it to you.
Okay, thank you very much. It was very helpful in presentation.
I mean, just one final comment. Between the balance billing protections for, these don't apply to short-term plans or healthcare sharing ministries or other non-comprehensive coverage, and these new subsidies, there should be no reason why anyone would be going to any place other than the marketplace if you have to buy coverage on your own. You shouldn't be, buying something that's less than comprehensive. There's good deals and it's additional protections that you would not get with some of the junk that's out there. So I feel like it's an opportunity for state-based marketplaces to really say, this is where you're going to get good coverage with comprehensive protections and now enhanced subsidies. So if it's not in your marketing materials yet, it should be. I mean, we're piling on here with the benefits of marketplace coverage, I think, and it's worth noting.
Okay, so any additional questions before we go to the next panel? Going once, going twice. Okay, I think that's a wrap.
Great.
Joanne Volk, thank you so much.
Yeah, thank you.
Georgetown,
Appreciate it.
and I really do appreciate it.
Great. Take care.
We're going to go to our next panel from the Maryland Health Benefit Exchange. We've got Executive Director Michelle Eberly, and I believe we've got Johanna Fabian Marks here as well from the exchange. They're going to give us an update on the state reinsurance program that was just alluded to a little bit earlier, and the implementation of the young adult subsidy program, or the pilot program. And so, Michelle, can you unmute? You're muted, and Joanne lead. Oh, Michelle, okay. Michelle, somehow we're not hearing you. Okay, we're gonna try to figure out the technical problem. Michelle, are you there? Can you hear me? Joanna, are you there as well?
I'm here. Yeah, I can check if Michelle's having trouble getting her audio working.
Okay. And by the way, we got several people don't seem to have the slides that were sent. So Jennifer, it might be good to resend those slides that we just were alluding to, so people can keep an eye. Maybe it went to their spam, who knows? But well, Joanna, as we're trying to figure out Michelle's audio problem, I don't know if you want to, maybe, I know we have a slide presentation here from the exchange. I don't know if you can wing it for her, or you want to talk about whatever you were going to talk about. And hopefully in the meantime, Michelle's audio will be resolved. We can go back to her, however you want to handle it.
Yes. Yeah, I can. I think Michelle was going to do an intro and then hand it off to me to walk through the slides. So
Okay.
She can jump in again when she's able to get her audio working. But we're very pleased to be here today to present to you about the reinsurance program and the young adult subsidy program. So, and I'm Johanna Fabian Marks, Director of Policy and Plan Management at the Maryland Health Benefit Exchange. Michelle's our Executive Director. I know you all know her. And if we proceed to the next slide, you can see our agenda for today for the presentation. So first, I'm going to provide some background on the reinsurance program and an update on the program's performance, and then review the program's actual and projected cost and enrollment data. And lastly, I'll cover the timeline for a potential waiver renewal and share some high-level information from our first round of what we're calling carrier accountability reports. And then I'll wrap up with an update on our implementation for the first year of the Young Adult Subsidy Pilot Program. So if we move forward, we'll get to the reinsurance program. And I just wanted to start with a quick refresher on how the reinsurance program works. And again, I know this will be familiar to you all, but just a reminder that reinsurance reduces premiums in the individual market by covering a subset of insurers' claims. And then because premiums are lower, the federal government spends less on premium subsidies and passes on those savings to the state to spend on the reinsurance program. In the chart at the bottom of the slide, you can see that the MHBE board has chosen to hold the program parameters constant since the start of the program. So from 2019 up through 2022 is the most recent year that we've set program parameters for. So that means that for people who have more than $20,000 in claims per year, reinsurance covers 80% of those claims up to $250,000. We've also consistently applied a dampening factor, as you can see at the bottom of the chart, and that adjusts carriers' reinsurance payments to avoid quote unquote double paying insurers for high cost enrollees under both our state program and the federal risk adjustment program. That factor is determined by the MIA, and that does shift a bit year to year. So just a little quick background before we move into the program updates. And So I'll just review some data on the program's performance to date. As you all know, and we love to share, premiums are down more than 30% compared to 2018, the year before the program started. After 3 years of double-digit premium decreases, average premiums will be increasing slightly in 2022, which is not unexpected. They'll be up about 2% on average. At a high level, you could say the carriers have just about fully baked in the effects of reinsurance on the market at this point, and so we're returning to a stable dynamic of low premium growth, but from a much lower baseline than we started with in 2018. And then, so you can see the premium information in the blue chart on the left. On the right, we've got some information in green on enrollment. So in 2021, total individual market enrollment increased about 9% compared to the previous year. That's including enrollment through Maryland Health Connection and off exchange. And while we can't attribute that purely to reinsurance, as the pandemic clearly had a significant role in driving people to get insured through the individual market, we can say that the lower premiums resulting from reinsurance set the stage for that enrollment surge. Almost all of the increase in enrollment came from people who are not receiving any federal subsidies. That is, they're paying the full cost of their premium. So you can see in the chart, we had growth of 36% in unsubsidized enrollment on exchange. That means individuals who were over that 400% federal poverty limit, although with the American Rescue Plan Act, as Joanne mentioned, those individuals are now eligible for some subsidies. And then we saw 13% enrollment growth off exchange, where federal subsidies aren't available. So when rates were climbing before reinsurance, we saw these higher income people leaving the market because they were having to bear the full cost of the premiums. But now we see they're driving enrollment growth, which is an indicator that the reinsurance program is successfully reducing premiums to the point where people are finding them more affordable. The next slide provides some more information on Maryland premiums and how they compare to national averages. So when we take a look at this comparison, we can see that Maryland really is ahead of the pack. Our average lowest cost premiums at each metal level are about 20 to 30% below the national average for 2021. And on the graph here, you can see the national average premium for each metal level shown with the dotted line, and then the Maryland premiums with a solid line. So in 2018, before reinsurance started, our premiums were much closer to the national average. They pretty much lined up with them, with the exception of gold plans. But since then, they've fallen significantly. And in fact, in 2021, we had the third lowest average premiums for on exchange nationally, according to data from CMS. So we've really seen the success of the reinsurance program reflected in our premiums. And then on the last slide in this section, we just see a more detailed breakdown of the estimated effect of the reinsurance program on each carrier in the individual market. So we can see that without reinsurance, we could expect 2021 rates to have increased by an average of 23% or more, depending on the carrier. Whereas with reinsurance, we saw that in 2021, each carrier had at least an 11% decrease in rates. And then moving along, I have some data on the program's performance in 2021. So, let me correct that and say 2020. So 2020 is the most recent year for which we have full data, so the most recently completed calendar year. And this slide gives a quick snapshot of the program cost and federal funding that we received for 2020. So as you can see, we're paying out about $400 million to carriers in reinsurance payments for 2020, and we received about $447 million in federal funding. So for last year, federal funding will cover the 2020 costs, and unspent federal funds will roll forward for use in future years. That 2020 cost of $400 million is about 6% than our actuaries projected, 6% more than our actuaries projected last year. And that's primarily attributable to both higher than expected enrollment in the individual market and higher than expected claims due to COVID. And I'll have a more comprehensive overview of the finances of the program in a couple slides. On the next slide, here we are. We just have a kind of snapshot of how the individual claims in the individual market broke down by whether individuals were eligible for reinsurance or not. So in the individual market in total, on and off exchange, paid claims in 2020 were about 1.2 billion for about 212,000 enrollees. The pie chart on the left shows that only about 6% of enrollees, that green wedge, met the threshold to qualify for payments under the reinsurance program, meaning they had more than $20,000 in claims in 2020. On the right, you can see that the 94% of enrollees in blue who didn't qualify for reinsurance payments accounted for about a third of claims, while the 6% of enrollees who did qualify for reinsurance accounted for about 2/3 of claims. The reinsurance program reimbursed about half of those claims. You can see that in the darker green. And then issuers covered the other half. So we have the market kind of neatly split into thirds here, with the reinsurance program covering a third of costs and insurers covering the other 2/3, 1/3 for enrollees who never qualified for reinsurance and 1/3 for enrollees who did qualify for reinsurance. All right, so lastly, in this program performance section, I'll briefly cover our financial projections for the program over the next couple of years. And I should start by saying that the numbers on this slide assume that the American Rescue Plan ends as scheduled at the end of 2022. As Joanne said, the ARP increases federal funding for 2021 and 2022, and its end would lead to a decrease in federal funding in 2023. The next slide contains projections for what will happen if the American Rescue Plan continues past 2022, but we'll stay on this one for now, where we're assuming it's ending. So to explain what you're looking at here, we've got program outflows in red at the top, and you can see those are outlined in red. At the very top, I think if you click once more, we have the actual or projected cost of the program depending on the year. So for 2021 forward, that's the projected cost. And then if you click once more, the 3 rows in red below show other draws on reinsurance funding that passed in the most recent budget. So these are amounts that are being pulled from the state funding that was originally dedicated to support reinsurance and are being used to fund other state programs, including the Medicaid program, which is what's indicated with the budget transfer line, the Young Adult Subsidy Pilot Program, and a Health Equity Resource Grant Program. And then in the middle in green, we've got the incoming funding to support the program. The first green row shows the actual or projected federal funding. And below that, we have state funding generated by the state premium assessment to support the program. And as Joanne mentioned, we just found out yesterday that we are getting more than anticipated federal funding for 2021. So that $474 million is about 140 million more than we had initially been informed by the Fed. So we're a little bit still in the process of updating these projections to account for that, but just wanted to flag that. And so then at the bottom, you can see our anticipated ending balance each year, looking separately at federal and state funds. And you can see that in the first couple of years of the program, federal funding exceeded the program cost, so we were left with unspent federal funds. And we expect that to be the case this year as well, as I mentioned. However, under current projections, looking at 2022 and future years, we do not expect to carry forward unspent federal funds and will be drawing on and expect to be drawing on our state dollars to support the program. Under current projections, assuming the American Rescue Plan does end after 2022, we expect to end the current waiver period, that would be the end of 2023, with about $200 million in unspent state funds. And then on the following slide, you can see how these projections are adjusted if we assume that the American Rescue Plan continues. So if you just proceed one more slide. There you go. You can see the numbers bolded in the 2023 column at right. So really what that leads to is an increase in the expected federal funding and an overall increase in our expected end of year state balance from about 200 million to about 260 million. All right, so then I wanted to briefly touch on the waiver renewal timeline. So as you probably recall, our waiver from the federal government for the reinsurance program approved for a 5-year period. So ours is going to end in December 2023 unless we apply for a renewal. CMS has provided guidance on the steps and timeline to renew. So this slide lays out a potential timeline for that process. And the 2 key dates for the feds are that we must notify them of our intent to renew no later than next October, that's October 2022. And we have to submit the renewal application in March 2023. So working backwards from that, the key action the state needs to take is to determine whether and how to continue state funding for the waiver program. In order to apply for the renewal, the state has to be able to identify a source of state funding, as we did when we initially applied for the program. So currently, we have the 1% premium assessment providing the kind of state guarantee of funding, but that assessment sunsets at the end of 2023. So if the General Assembly were to make that decision regarding funding in this upcoming legislative session, that would tee us up to submit our letter of intent to CMS later on next year. And then the second stage I'll mention that may come before the General Assembly, or the General Assembly may want to consider, that ties into this process, is determining whether to extend the Young Adult Subsidy Pilot Program and whether to incorporate that into the waiver renewal in order to try to get additional federal funding for that program too. That conversation could take place in the 2023 legislative session once we have data on the first year of the program. But it would be helpful to have a sense next fall going into the session of whether there was interest in that so that we could determine whether it makes sense to do work to incorporate that into the application that we would be submitting in early 2023. And then the last section here is on carrier accountability reports. So we wanted to just share with you all some of our work that we're doing on the reinsurance program with carriers to better understand their the conditions that are being reimbursed under the program and the care management that carriers are using to help manage those conditions. So our regulations require carriers to submit an annual report that describes their activities to manage the costs and utilization of enrollees under the reinsurance program, as well as efforts to contain those costs so that they don't end up hitting the reinsurance threshold. Our first annual report was for 2019 for the 2 carriers in the market that year. And that's our baseline report. We just recently got 2020 reports, and that will enable us to do an initial evaluation of the effectiveness of and savings from these carrier activities. The report collects a number of data elements, and I won't kind of read all of these, but broadly, it's, as I mentioned, there are initiatives to manage costs and utilization, how their enrollee population, so demographic and claims data on their enrollee population, the measures of the effectiveness of those carrier programs, estimated savings and the estimated rate impact of those carrier initiatives, and then some quality outcome measures for certain targeted health conditions in the individual market. And on the next slide, we wanted to highlight that we were collecting specific information on carrier initiatives targeting 4 state population health goals, which were diabetes, behavioral health, asthma, and pregnancy and childbirth. So those are our 4 areas that the state and other elements is working on. And so in alignment with that, we also collected information on those. What we saw in our 2019 reports was that carriers had some care management initiatives in these 4 targeted areas. Specifically, both had initiatives related to diabetes and one had initiatives related to behavioral health. And we gathered some information on how many individuals who qualified for reinsurance payments were enrolled in those initiatives. And then we also collected information on the top conditions among SRP state reinsurance program claims. And we looked at that by what were the most frequent conditions and what were the highest cost. And highlighted in blue, you can see the 4 targeted conditions that we were collecting additional information on. So you can see that there's a mixture here of kind of acute conditions such as cancers and hemophilia and respiratory failure, and also, some chronic conditions that we were targeting. So I was pleased to see that the ones that we selected did end up being among the most frequent and highest cost, and we're collecting and analyzing further data on these. And then on the last slide, to cover next steps, we are completing our analysis of the recently submitted 2020 reports, and we're going to be using this combination of reports as a basis for ongoing conversation with the carriers and exploring how we can work together to align care management activities for individual market enrollees with state population health initiatives, while also focusing on conditions that are driving reinsurance costs and involve potentially preventable costs. So we're still at the beginning of this process, but excited to be collecting this data and looking forward to moving this forward. And then lastly, I wanted to provide a quick update on the Young Adult Premium Assistance Program, or Young Adult Subsidy. So just kind of at a high level, everything's moving forward well. The board set the 2022 proposed eligibility and payment parameters earlier this spring. That included a public comment period on those. We've also got regulations in the pipeline. We're expecting proposed regulations to be published in a couple of days. Then we'll have a comment period and we'll be adopting those later this year. And our system is ready to go for open enrollment. Young adult premium assistance amounts will be displayed on Maryland Health Connection, and premium assistance will be automatically applied for eligible renewing enrollees. And that's a wrap on the presentation. Michelle, I know you didn't get to say anything to start with, so if you want to add anything, please do.
We'll see if my mic works now.
Yeah, we can hear you.
Yeah, very good. Very good. I just wanted to start, and I'll finish by really thanking the commission for supporting the efforts of the exchange and supporting the efforts of healthcare in the state of Maryland. Johanna did go over the numbers of increases we've seen from 20 to 2021, but what's really, and that's really marvelous. What also is really marvelous is looking at back pre-COVID, so from 2019 to 2021, and particularly in the folks that did not receive any subsidy, we saw an 68% increase in enrollments of individuals on exchange that did not get any financial assistance. So that's a clear demonstration of the success of the reinsurance program. We're at an all-time high for this time of year, nearly 168,000 on exchange. The program's working, it's working very well. We still see a challenge in that young adult population. However, that did increase significantly as well. It's up about 18%. But we do know we'd like to see that up significantly more. So that's where the Young Adult Subsidy Program will come in. And I just wanted to comment that, as Joanne had mentioned earlier, actually Maryland was first in the nation to implement all facets of the ARPA additional funding. So you should all be really proud of that work, that we are able to get money, those tax subsidies into our Marylanders' pockets just as quickly as they became available. So thank you. We'll take questions, and Johanna, thank you for presenting so well.
Okay, Joanna, do you have a few more slides here, or that is, well, before we go to Q&A, let me just, I understand the exchange is about to celebrate its 10th anniversary, official anniversary. So I want to congratulate you both on that achievement. Well, the 10 years is not so much an achievement, but what we've done with the 10 years has been, I think, an achievement for the state of Maryland. So that said, I'm looking for some raised hands for any questions of either Michelle Everly or Joanna Fabian Marks from the exchange. I see Delegate Bonnie Collison is in the house. Delegate Collison, welcome, and you've got the floor.
And I think I'm off mute now.
You are, we can hear you. And then Dr. Rockhauer, you'll be next after, and Bob Atlas after that. So, Bonnie?
Thank you very much, Senator. And I apologize that I was a little bit late today. So if this was covered, please excuse me. I know that I think we passed a law back in 2019 that said we were going to be looking at the some potentially different options in how we fund the reinsurance program, and that we were going to do a pretty comprehensive study of that. Has the study been done? Did I miss that, or is it in process? Oh, where's that now? Thank you.
Delegate Collison, we have not done an updated study on how to fund it. We've been using the federal pass-through funds and then the state assessment. So we haven't done an updated study on how to fund it. The studies that we have been doing are how much funding do we anticipate that we will need.
So are we open to looking at the other part of that? And I really, first of all, I should have said thank you, because what I heard was really comprehensive, and I really appreciate the work that you all do. But I'm wondering if we can also look at this other piece as well as we go forward. It may be that we have the best model, but I know that a lot of states are now adopting, reinsurance programs. I think we were kind of one of the leaders in this, and they're looking at all kinds of options. And there may be things that, we might find that meet the needs that are getting more clearly defined through our studies.
And we certainly are open to do that. Absolutely.
Okay, well, Bonnie, just say that's a good question, because I think if you looked at the timeline, I think those conversations, discussions are probably going to have to take place, maybe even the 2022 session, even though some of the timelines really technically aren't till 2023. So I think that's very timely, topical thing to put out on the table. Dr. Rockhauer, you're next, followed by Bob Atlas.
Yeah, thank you. I noticed on the slide that was covering the disease states that took the most dollars, and I saw that end-stage renal disease was one of them. And maybe I'm wrong, but I thought that most of that was covered by federal dollars and, and not, going through the exchange.
Yeah, I will say that caught my eye for the same reason, and that's not something that we've dug into with the carriers yet to understand more about. If any of the carrier representatives want to speak to that, though, please feel free, but that is something that I would like to look into more.
Okay. Okay. Well, we'll have to continue that conversation. Bob, you're next. Bob Atlas.
Thank you. Excuse me. Good. Very good and thorough presentation, Johanna. And good pick up when Michelle abandoned you there at the beginning. The couple questions, maybe going in reverse order. Toward the end of your remarks, you mentioned about planning to get carriers more involved in these population health initiatives. As many on this panel may know, we've got population health requirements committed in our Maryland model agreement with the federal government under something called the Statewide Integrated Health Improvement Strategy, or the SIHIS for short. And the reason I note this is because, we are under, the clock is actually ticking on meeting these milestones under the SIHIS. While I'm encouraged by the point that you're, getting to work on it, the fact that we're just getting to work on it now, when the feds are going to be measuring our progress on it within the next couple of years, suggests, we're not getting the insurers involved and producing any results is going to be very, very limited in the time frame that the feds are measuring us. So I wonder, one question, because in the agreement on the SIHIS with the feds, there's a provision that says we can revisit the goals in early 2022. We can revisit in the first quarter. We can revisit those goals in light of the impacts of the pandemic. And I wonder if your schedule, in fact, has been stalled as a result of the pandemic, and that might be a basis to make the point with the feds on a little bit of relief there.
That's a great, set of questions and comments. I mean, I would say that our engagement is really specific to the individual market, which is a small sliver kind of overall. I know that HSCRC and MDH are working kind of more broadly with the carriers and MCOs on the SIHIS goals. So we really want to align with what they're doing and kind of make sure that that's being reflected in the individual market. I would certainly defer to those other agencies regarding timing. I don't think that COVID has necessarily impacted our progress specifically because we're doing this claims-based analysis. It's kind of a slow process for us to, we have to wait for the year to end, for claims run out, for the data analysis to happen. So we're not getting the reports until about 6 months after the end of the calendar year. So just given the timing of the reinsurance program, it's just taken us a while to get these first couple of reports ready.
And I'll just add to Johanna that we do participate in the population health management group. And as Johanna had mentioned about when we were looking at and talking to the carriers about what conditions to target, we're working hand in hand with other agencies to see what are the population health needs for the state as a whole, so that everything we're doing, we're trying to do lockstep with the state needs as a whole. What the focus that we're looking at it from is that we are expending funds on these high dollar claim costs. So we want to make sure that as a state expending funds through the reinsurance, the other side of that is that there's active engagement to lower those costs. So that's where we come in line and focused on that and on the accountability reports. But by all means, everything we do and decisions we will be making are collaborative decisions with the carriers and with other health initiatives for the state.
Thank you both. I will say, you use the word accountability. I mean, one thing that we in the hospital field always want to remind our partners outside of the hospital field is, the agreement with the federal government is an agreement with the state on making certain commitments, and it's not just the hospitals that need to be accountable. So we do hope that other parties, including the insurers, will step up and be accountable for the production of improvement in our state. One other thing, just going back to the whole reinsurance program, is there any reason to think that there won't be movement to keep the reinsurance program going? All the reauthorizations the General Assembly needs to do, all the funding. The reinsurance is making a difference in a number of positive ways. And so the question really is, should we be on alert that there's something, that there are possible pitfalls looming that could cause the reinsurance program to, other than I'm not counting on the extension of the American Rescue Plan beyond the given time frame, but anything within the state that looks like a risk.
Is it?
No, we're
Is somebody in particular? Are you directing that to Michelle or Joanna, or just that's
Anybody who, start with Michelle and Johanna, but that might also, that question might also apply to our legislative leaders and some others.
So I'll just start briefly, and then Johanna can add in. The only risk at this point in time is if we don't have any state funding to put against the program, because part of the requirements of the federal government is that we have to have state funds. So that's the risk from within our state, and that of course would go back to that state assessment. There are, beyond the bigger risk at the federal level, I think would be what happens with the ARPA permanent subsidies. And if that lowers the costs such that the premiums are so low, I think as Joanne said, this is unknown territory. We'll have to really relook at what we're doing and why we're doing it and how we're doing it. But I don't envision us to have those answers, for several years. Johanna, do you want to add to that?
No, I think that covers it. And I guess I would just say that we've kind of broadly heard support from all stakeholders for continuing the reinsurance program.
Okay, and as Delegate Carlson mentioned, that it's one thing to the question of how one funds it, is going to come up again, and General Assembly is going to have to address that in some way, shape, or form. But Chair Kelly, I see that you've weighed in with your hand.
Yeah, one thing I think that Bob brings up, which struck a chord with me, is that it might be good if this commission and the health department could put together some kind of an education program for people, maybe late spring, who are running to be governor of the state, because a lot of them are totally ignorant of all of this. This is so major, and they don't know about it. In many cases, they're thinking about everything else, and they're going to need to play a leadership role and to have a department that is on track, and not to start from scratch with a pile of people who know nothing of what we've been involved with. I won't say more, but it's occurring to me, we've heard so much today that a lot of people who think they want to be head of the state of Maryland ought to know and ought to be clued in on. And I'm just wondering if there's something we could put together, maybe late spring or near the end of session or something, to make sure before we leave town that folks who want to be governor are aware of the importance of this, of where we are, of what's got to happen next, and also would show their hand to some extent in terms of where they are on these issues and how educated they are or are not. I won't say more, but that did occur to me as I listened.
I would, Chair Kelly, we have a briefing in the Finance Committee at the end of the month on some of these same issues, actually, and I think maybe HGO will be part of it too. I know the finance. Maybe we should invite all the declared candidates for governor to actually, participate in or at least attend the Finance Committee briefings at the end of the month, which is going to include reinsurance, the adult subsidy, and some of the other issues. I think it's not a bad idea to kind of get those folks up to speed. But okay, well, why don't we leave it at that, as you say, Chair?
Okay.
We'll say no more. We want whoever is next governor, we want them to be educated on these highly important issues.
Yeah, we don't want them to take us back.
Absolutely not. Okay, I'm looking for some other questions here. I'm going to go through. Again, it's good to have Joanne and Michelle here. Okay, let's see. And Finance Committee meeting, somebody asked about, we have briefings both on the 28th and 29th of September, and both of those cover some of the same subjects we're addressing today, from MIA, from the exchange, et cetera. So you get a second crack. Okay.
And I saw that Sandy Walters had his hand up.
Okay, Sandy, you're raising your hand the old-fashioned way with your hand.
Yes.
So you've got the floor.
Okay, thank you. Let me comment on your question about diabetes for a second. I think a lot of these people are first-time insured people, and there's an elimination period before you're covered under the federal government for diabetes, not for diabetes, for transplant on kidney and all. So I have a feeling we might be getting some early claims within that area. Now I'll go to why I really want to raise my point. Originally, when we talked about the young adult funding for that, part of our rationale was we had excess of money because the federal government was basically paying entirely for the program. And if you went back to slide 12, it showed if that extra funding goes away, there's a major hit to the balance that will be in the budget. And I'm not sure how many years that will suffice before it's a negative and we would have to raise additional money. So I'm concerned about that, and I'm not sure what we're doing to watch that, because I'm not sure what's going to come out of the federal government for dollars. I believe the reinsurance program is going to stay around, but that extra funding will not, and that has a precipitous effect, I think, on where we're going. So I want to know if we've looked at that and we have any contingency plans in that area.
Okay, well, I'll let Michelle or Johanna respond to that. I would note that, don't forget that that young adult subsidy, that's a pilot program that's only there for 2 years. So that's not like, just the world as it exists in 2023 will probably be a little different than what it is now. So we'll have more information, and even in the way the bill was written it's subject to appropriation. So there's going to be a budgetary aspect. Michelle or Joanna, you want to weigh in on that issue?
Johanna, why don't you address?
Sure. Yeah, I would just agree with what you said, Senator Feldman, that it is just a 2-year program at this point. So there will need to be a conversation as that's kind of nearing its end about whether the state wants to do it, and if so, how to fund it, and if so, at what level. I think we do have 10-year projections for reinsurance funding. So I just presented the numbers for the first 5 years because that's the period in the waiver period. But we do have numbers on our website kind of projecting out what funding could look like going forward past 2023.
Thank you.
Yeah, any additional questions, whether the old-fashioned raising hand on the screen or using the hand function, raise hand function on the computer? Okay. No, I don't want to kind of exclude anybody here, but I don't see anybody else with the raised hand. So,
Brian,
Senator West.
Okay. Senator West too with the old school raised hand. Okay.
Yeah, old dogs can't learn new tricks.
Okay, fair enough.
Pick up on what Dolores said and maybe expand on it. My guess is that the average member of the General Assembly has no idea what we've done. The average member. The knowledgeable members, the members of HGO and the Finance and the Senate probably do. But get beyond that, my guess is most people do not. And so my question to Michelle is there something on the exchange's website which explains in simple language how this works, what we've done, and how we've made sure that it's going to continue to work for at least the near-term future?
We have a bunch of information on our website about the reinsurance program. It simplified in terms of how it's going to go forward. I think that's questionable because most of our things are deep dives, and we can certainly put something simplified together. But yes, we have just a ton of information on not only the reinsurance program, but other committees, affordability committee, and all the history is out on our stakeholder site.
Okay, just so long as there's a resource that either incumbents or candidates could access easily in order to find out how the system works. And what we've done, which has made all the difference in the world between it working and it not working.
We'll go back and take a look at that and see if, just for this purpose, to have a very simplified one pager on there, we can certainly have that.
Yeah, maybe even a pamphlet, 3 or 4 page. It doesn't have to be 1 page, but something that's easy to understand that people can get easily download and then can read and can understand what they've read. That's my thought.
Okay, I think that's a good thought. First of all, I think we have a lot to brag about here in Maryland, so it'd be good to, have in our legislators' hands stuff to talk about all that we've done. Co-Chair Peña-Melnick, I think we don't have any more questions. I think this was an excellent presentation on a lot of stuff, a lot of good stuff from both panels, and just want to make sure. Okay, Steve Rockhour says they could visit their doctors to see how the system works. That was Dr. Rockhour's comment. And so,
Right.
Delegate Peña-Melnick, any closing comments? That we do have the next meeting isn't until December 9th to be specific. So, we have a tentative agenda, but if there's some things some of the members would like to see part of that December 9th interim meeting, obviously you can weigh in with us, make the pitch as to why something might want to be or should be added. But with that, Delegate Peña-Melnick, if you have any broad observations before we adjourn for the day here.
Yeah, I think that there was a question in the chat room regarding when is the Finance Committee having a briefing. I don't know that it was.
Right, yeah, it was, so I mentioned it, it's going to be September 28th is going to be the one where a lot of the stuff we covered today will be the briefing. I think we're having another briefing the following day on the 29th dealing with Medicaid financing and budget issues. But I think on the 28th in particular, the reinsurance issues and the young adult subsidy program pilot, I think are going to be the topics on the 28th of September in the afternoon. So.
Yeah, no, I think it was a great meeting. I just asked the same thing you just asked the commissioners, if there are any other topics or any information that they want to see, to please send it before December. After December is too late, so send it before December so that we can have an opportunity to address it. Thank you so much.
Yeah, and I'd also say that each one of these reports, because if everybody is involved, we issue a report by December 31st, and we've done this 4 times with this commission. And every time in the first 4 years, those reports have given rise to bills that have passed finance HCO. So, we take this pretty seriously, and we want to use that December 9th meeting, for more substance, and then to produce a report that will likely give rise to some action in particularly the 2 committees of jurisdiction and in the budget committee. So, so it's been a good model, and I think it'll carry on here in 2021 as well. So unless anybody has any final thoughts from any member of the commission before we adjourn today? Okay, well, seeing none, we kept it to an hour and a half, 1 to 2:30, and seeing no hands or anything else, I hereby declare the hearing briefing adjourned for today. Thanks.
Great meeting. Bye.
Thank you, everyone. Great meeting.
Bye-bye.
Bye, everyone.